Clicking and zooming. Setting up your Facebook lead day or live. I got one. I got two. I got
No, I'm
smiles.
laughing because I didn't get it.
You got Brandon rolling his eyes. All right, welcome to February the 3rd, 2026. This is Start With Safety. I am John Wojciechowski. I hope everybody has got off to a great start for 2026. It has been busy at the Utah Safety Council. We appreciate that. We've been busy with MSHA classes and traffic classes and first aid classes and OSHA classes. I'm kind of jumping to the bottom of my agenda here, but with all that busyness, I wanted to remind everybody with the new year, we got a new set of funds from the Utah Labor Commission and our scholarship program. And so I'm not going to dive into the details, but I'd love to do that. If you want to reach out to us on our website at utahsafetycouncil.org, you can call us, you can email us, you can come visit us here at our Sandy building and talk to our occupational MSHA manager, Karen Quillon, or any one of us would love to tell you about the great opportunities the Utah Labor Commission will afford you and your company and veterans to take some classes to help you stay safe, help your workplace stay safe, and save lives together. So going back to some business, yesterday was Groundhog's Day. That's my understanding. We have 6 more weeks of winter coming. So it's been a hard, crazy winter in Utah, right? It's like springtime in February. So it sounds like we have 6 more weeks of that. But stay safe. It sounds like it might be a hot, dry summer. And we look forward to, helping educate on how we can survive that coming up. So February does bring President's Day, Monday the 16th. We will be closed that day. We will be open before on February the 13th, which is the big Valentine's Day weekend. So if you need some help with Valentine's Day ideas, come on in and see us. We can talk scholarship and things to keep your loved ones safe at home. So I think that's all I have. So we're going to invite Fabiana up to continue our Start With Safety for February. Okay, thank you.
Woo. Yeah, my name is Fabiana, and I'm just here to give you some news about our Lunch and Learn with Scott Martin. We're gonna host that on February the 18th at 12. So be we're gonna keep you guys like on social media. So we'll be sending like emails, and we'll be posting some information about this Lunch and Learn. It will be great. So sign up for this. Let's see for our. This is not working. Okay, there you go. For our Women in Safety News, we have our first event of the year, which is in March. And you don't want to miss this event. Shante Jackson will be here presenting. Please keep an eye on our social media. Today, we will be posting more information about what she will be presenting. I'm very excited for Shante to come here, and it will be in our Sandy office, and we will have breakfast. So it's free, and please sign up for this. It will be awesome. And for our membership news, today I would like to talk about more for our first tier or category, if you would like to say it that way. In our membership, we have different categories, and this will be the first one. One of the things that you have many benefits with this tier, you pay 250 per year, but your cost for this, your value cost for this is like more than $800. And what do you get with this 250? You get an OSHA 10 hour training, first aid, you have different type of events and award that you can participate for free. You have different type of training and product discounts, like 30% discounts on these trainings. One of the things that we have the most utilized benefits in the month of January is first aid, CPR AED, and we had courses in on-site. So you see like one or two benefits in your membership, it pays it itself. If you have more questions about your membership, or you would like to have if you would like to know how to use the benefits, you can always like email me, and the email is right here, and phone number, my extension is 316, or you can also scan the QR code and have more information. It goes directly to our website. Next, we will have Karen Piriona. She will be talking about those grants that John was talking about, so scholarship programs news.
Thank you, Fabi. Good morning, everyone. The Occupational Safety and MSHA scholarships offered through the Utah Labor Commission are a workforce development investment, right? They help employers such as you and all of the companies in Utah Safety Council that are not only members with us, but also non-members. They help you access professional safety trainings without cost being a limiting factor. So by supporting education in occupational safety and health, MSHA, compliance, these scholarships contribute directly to safer operations, stronger safety programs, and more informed leadership within Utah workplaces, right? So funding is limited. So if you're interested, we encourage you to apply early. And to do that, you may email msha@utahsafety.org or occupational@utahsafety.org, or just give us a call at 801-746-SAFE, extension 304, and ask for Karen. Thank you. Have a good day. Next, we'll have Yvette Stephanie.
All right, I'm just here to introduce our esteemed guest honor speaker, Brandon Stone. With 16 years of dedicated service in the fire service, Brandon brings extensive frontline experience in emergency response, public safety, and leadership. He has been with the Utah Safety Council for 3 years, serving as an instructor where he focused on education, prevention, and community outreach. As a committed advocate for community services, Brandon is passionate about improving public safety through training, mentorship, and proactive engagement. Please welcome Brandon Stone.
Good morning, everybody. My name is Brandon. I am here today to talk about cardiac arrest, heart attacks. It's February. It's American Heart Month, so we're here to talk about heart and the things that can happen to our heart and the care for it when it does happen. Here. So the statistics. Every year, year after year, heart disease is the leading cause of death in the U.S. While the numbers are trending down slightly and are being caught up by cancer, it's year after year that heart disease causes the most deaths to Americans. An interesting way to put it, because I don't know, 702,000 people, it's a big number, doesn't really mean a lot to me. Another way to put that number, though, is every day here in the US, 2,400 people die from cardiovascular disease. So another way to put that, that's the equivalent of 6 fully loaded 747s taking off, crashing, everybody dying every day. It's a lot of people when you think about it that way. It's a lot of people. So what is a heart attack? The heart is an organ, right? Supply blood by blood vessels. When a heart attack occurs, one of those blood vessels has become partially or fully clogged, like pictured here on our slide. You can see that blood clot has formed. What happens is plaque starts to build up on those artery walls. And when that plaque starts to build up, the blood platelets collect on that plaque. And eventually a blood clot is formed. So what happens to that heart muscle is that heart muscle is no longer getting oxygenated blood. That heart muscle is dying, it's atrophying. And you can see it there pictured on our slide, how that heart muscle is darkened. It's not getting oxygenated blood, it's dying. So that's basically what a heart attack is. Some of the signs and symptoms that can be caused by that blockage. Pressure, pain, discomfort, pain that radiates. That pain can radiate from the center of the chest out to the shoulder, up to the jaw, to the back, down an arm. Shortness of breath, dizziness, lightheadedness. My favorite sign and symptom of heart attack, not that it's good to have a favorite, but my favorite is an impending sense of doom. And it's my favorite because it's fun to say, but it's a very, very real thing. If somebody ever tells you they feel like they're about to die, believe them. That impending sense of doom, a person will have a sense when something's not right. They'll have that feeling. So it's a very real one. They could be pale, sweaty. Women especially will experience nausea, vomiting, and indigestion, as well as jaw pain and shoulder pain. One of the interesting things, if you're ever out there in the world and you come across somebody that doesn't look like they're feeling very well, and you go up to them and you say, hey, you know, it doesn't look like you're feeling very well, and you start talking to them, and they're exhibiting these signs and symptoms that we've talked about. If you were to say to them, hey, I think you could be having a heart attack. Now, don't say you're having a heart attack. That's a little hard. Say you could be having a heart attack. The most common response to that is for the person to say no. Never had a problem with my heart. Couldn't be. But heart attacks, a vast number, it's 2/3 of heart attack sufferers are first-time heart issue people. They've never had a problem with their heart before. This is their first experience with it. So what is the first aid treatment for a heart attack? There's a few things we can do to help somebody that's suffering a heart attack. The first thing we want to do is we want to call for help. We want to make sure somebody's coming. Call 911, get EMS responding. Once we've done that, we want to get this person into a position of rest, get them into a position of easy breathing, open up any restrictive clothing. If there is an AED in the vicinity, we want to retrieve that, have that on hand, ready to go just in case. There's one other thing that we can do. We can give this person aspirin. Aspirin, it does a couple of things. There's a couple of reasons that we give aspirin in the instance of a heart attack. The first thing it does is it's a vasodilator. It makes blood vessels open up. The second thing it does is it's an anticoagulant. It helps to break up blood clots. So by giving this person that's suffering a heart attack aspirin, we're hoping either to break that clot up so we can get more blood to the heart, or to open that blood vessel up so that more blood can get past that blockage. That's what aspirin does in a heart attack. And then we're just going to stay with our person that's feeling ill. We're going to stay with them. We're going to be a calming, reassuring presence while they're going through this. Now, a heart attack is a very different thing from cardiac arrest. If left untreated, a heart attack can become cardiac arrest, but cardiac arrest is a very different thing. So I don't know, you guys remember like your high school anatomy. The heart has the 4 chambers as pictured here. For the heart to effectively push blood throughout the body, those 4 chambers need to beat in a coordinated rhythm. The rhythm is called a normal sinus rhythm. That's the rhythm that all of us are in. We're upright, we're conscious, we're in a normal sinus rhythm. It's possible somebody might have some V-tach, some V-fib, some other minor arrhythmias, but for the most part, we're all in normal sinus rhythm, a good productive rhythm. Those 4 chambers are beating in a coordinated rhythm, pushing blood throughout our body. When those 4 chambers, for whatever reason, get out of that good coordinated rhythm, That's called an arrhythmia, a bad rhythm, an unproductive rhythm. When the heart gets into an arrhythmia, those four chambers are no longer beating in a coordinated rhythm. The heart's not able to push blood through the body. We collapse, we stop breathing. That's cardiac arrest. Signs and symptoms of cardiac arrest. It used to be that we talked about checking for a pulse. When we were checking on somebody that we thought maybe was in cardiac arrest, we used to check for a pulse. But the powers that be, the people that develop these programs like CPR, these procedures, they came to understand that people don't want to get involved in performing CPR. They're intimidated by it. They're scared by it. So they wanted to make it a little bit less frightening, a little bit easier for a person that really doesn't know a whole lot to get involved and help somebody with CPR. So with that, trying to make it easier for people to do, more comfortable for people to do, they took away checking for a pulse. We no longer check for a pulse. We have two criteria for doing CPR. The person's not breathing normally and they're not responsive. Now, when we say not breathing normally, they're going to be in what's called agonal breathing. You might have also heard it called the death rails or the death snore. A person that's exhibiting agonal breathing will desperately gasp for air about 6 times a minute. And people will sometimes worry, well, what if I don't know if they're not breathing normally? How will I tell? You're going to know. You're seeing somebody taking their dying breaths. It's upsetting. It's disturbing. You're going to know. You're going to recognize it. So really, that's all we're looking for. They're not responsive and they're not breathing normally. A way to check on responsiveness, if you're not certain if the person is truly unresponsive, you can just take your knuckles and just kind of put a little pressure on their sternum, on that breastbone, and just give it a little rub. It's a painful stimuli that will cause a response in somebody who is responsive. So if you give them that painful stimuli and there is no response, pretty good indication they're not responsive. And then if they're not breathing, we're going to perform CPR. A condition that's gaining a growing amount of awareness is something called sudden cardiac arrest. Now, in the past, we always have thought that cardiac arrest happens to somebody that's older, happens to men more than women, happens to people of certain races more than others, happens to people with certain medical histories more than others. But we've come to understand that no, cardiac arrest is an equal opportunity agent. It doesn't care about any of that. It happens to people across all age groups. It happens to both sexes, people across all races. It happens to people with no significant health history. Sudden cardiac arrest strikes everybody equally. There are some risk factors that have been identified in sudden cardiac arrest. Family history, smoking, high blood pressure, high cholesterol, obesity, diabetes, and an inactive lifestyle can all attribute to sudden cardiac arrest. There are ways that we can manage it, that we can help to prevent it. We can eat a balanced diet, regular exercise, regular checkups, screening for heart disease, control our blood pressure and our cholesterol. Those are all things that we can do to help prevent sudden cardiac arrest. So what is the care for sudden cardiac arrest? The first thing we need to do is call for help, right? We have to get help coming. If you're directing somebody else to go retrieve an AED and call for help, make sure that you're very specific when you do give that order or that request. If you were in a group and somebody were to go down with sudden cardiac arrest, and you just set out to the group, hey, somebody call 911, most likely nobody's going to do it because everybody assumes somebody else is going to do it. So be very specific. Use a name, get their eyes when you give that direction. Hey, you call 911, get the AED. And it is important, get the AED. That's an important part. We want to get that AED to this person as quickly as possible. And then we're going to start with our cardiopulmonary resuscitation, CPR. So with CPR, Form is very important. The first piece of form that I would talk to you about is when we're doing CPR, we want to focus all of our force on the heel of our hand. All we really want in contact with that chest is the heel of our hand. We want the heel of our hand right in the center of the chest. You can feel in the base of your ribs, you have a pointy bone right there. That's your xiphoid process. That is the tip of your breastbone. We don't want to be pressing on that. When we're trying to figure out where to place our hand, if we find that xiphoid process and we feel there's almost a little notch right there, we want to put our hand just above that notch. And you can see on this slide how that's pictured there. There's that little notch. We want to place our finger in that notch and then place our hand, the palm or the heel of our hand, just above that in the center of the chest. That's how we can find where to place our hand. Now, you might think, well, if I can find the placement for my hand just like that right through a shirt, I don't really need to take the shirt off to do this. And you've got a good point there. Yes, you can find where to place your hands through a shirt, but I would suggest taking that shirt off, because as soon as an AED shows up, that shirt has to go. We have to remove that shirt to place that AED. So we might as well do it right from the start while we're there, just get it taken care of. Actually, let me go back. The other parts of form that I would talk to you about. So we're going to place the heel of our hand in the center of that chest. We're going to take our other hand and we're going to lace our fingers together like this. And we want to get our shoulders up over our hands. And then we want to lock our elbows. We want to be directly over our hands for a couple of reasons. One is it makes it a little bit easier to do the compressions. We can use our body weight when we're doing these compressions, because CPR is draining. CPR is hard. If you're just trying to strictly muscle it, you're going to wear out fast. So use your body weight as much as you can to get that compression. The other thing that does is if we are directly over our hands with our shoulders, when we do our compression, we're going to do a straight down compression. If I'm not in this position, if I'm not up over my hands like this, if I'm down off to the side like this, I'm muscling it and I'm not getting a straight down compression anymore. I'm kind of pushing to the side. So the quality of my compression will be less. So we want to get a nice straight down compression, good quality compression. Good quality CPR is really important in trying to save somebody's life. There are two different ways, I guess you could say, that CPR can be performed. As I mentioned, they tried to remove hurdles. They want people to get involved in performing CPR on other people. People generally are not all that enthusiastic about doing it. And I get it. The idea of coming across a stranger on the street and they're in cardiac arrest and now I'm going to put my mouth on their mouth, I don't want to do that. In my time in the fire service, I never had to do mouth-to-mouth because we had tools to breathe for people. So them understanding that that is a big hurdle in people wanting to get involved in performing CPR, they took that hurdle away. They've come out with hands-only CPR. Hands-only CPR is no breaths. It's just doing the compressions. We're going to do compressions at a rate of 100 to 120 a minute. And we do want to make sure when we call 911, we're going to do our compressions. We want to make sure that if there is an AED available, that we get that retrieved, we get that brought to our person that is in cardiac arrest as quickly as possible. With hands-only CPR, the rate and the depth are your focus. You're not worried about breaths. So you're going to go hard and you're going to go fast. If you are in an area that is covered, is protected, I guess, by a professional fire department, that's going to give your person that's in cardiac arrest a chance at survival. But I will tell you this, if this is a person that matters to you, give them the breaths. Do the traditional CPR. 30 compressions, 2 breaths. We're still going to keep that rate of 100 to 120 compressions a minute. We're going to do 30 compressions. We're going to do 2 breaths. That's 1 cycle of CPR. If we have the AED and it's applied, we're going to do 5 cycles of CPR. 30 compressions, 2 breaths, 5 times. And then our AED is going to prompt us to analyze that victim again. When we're doing our compression, we want to compress the chest about 1/3 the depth of the chest. In an infant, that's about an inch. If you are doing compressions on an infant, compressions can be done on an infant by holding them in your hand with their head in your hand, and we can do compressions with 2 fingers. We can also lay them on a table or on the floor. We can use 2 fingers or we can use 2 thumbs to do those compressions. And like I said, we're looking for 1/3 the depth of the chest. In an infant, that's about an inch. In a child, that's about 1.5 inches. Now, when doing compressions on a child, we probably don't want to use both hands. That probably might be too much force for the child. Maybe just use the one hand. There are some songs out there that can help us keep the rhythm in when we're performing these compressions. The most famous is "Staying Alive." I don't know if you've ever seen the Office episode. They do a pretty good job there. But it's the "Staying Alive." There are other songs, a personal favorite of mine. This might be a little dark, but "Another One Bites the Dust" is a good one. The Imperial Death March from Star Wars, even "Baby Shark." I don't know if that song ever lived in your head, and I'm sorry if it did, and I brought it back. But those are all songs that we can use as a tool to help us keep that rhythm when we're doing our compressions. When using an AED, let me back up really quickly. You've probably heard that you're going to break ribs doing chest compressions. And chances are you're going to. But if you're doing a good compression, just the heel of your hand is in contact with that chest, you're not going to break ribs. What you're going to do, you will feel snapping and popping. What you're going to feel, if it's just the heel of your hand on that chest, what you're going to feel is where the ribs and the breastbone come together, there's cartilage. If it's just the heel of your hand pressing down on that breastbone, what you're going to feel and maybe hear is that cartilage tearing and snapping. That's what you're going to feel. Now, if you're doing your compressions for a while and you start to tire out and your form starts to break down and your whole hand ends up on that chest, yeah, you're going to break some ribs. That's okay. Nobody's going to get upset. You're not going to get in trouble. It's honestly to be expected. So do the best you can. Try to keep just the heel of your hand on that chest. But if we end up breaking some ribs, that's to be expected. When it comes to the AED, so this is a trainer. It's not designed to replicate any specific model. It's just a generic, not really designed to look or replicate any specific model. When it comes to using an AED, we do have to prep that chest. If the person is a hairy person like me, we do need to shave that hair off. These pads have a sticky conductive adhesive. That adhesive needs to get in in complete contact with skin in order for that pad to be able to pick up that heart rhythm, to register and analyze that heart rhythm. So we need to shave that chest. They talk about sometimes that if you don't have a razor, if you have a second set of pads, you can use that as like a waxing strip. Put a pad on there and rip that guy off to try to remove the hair that way. They probably won't need CPR after that. They're gonna. But if you don't have a razor, you don't have a second set of pads, go ahead and put that pad on. It's probably going to just tell you that no shock is advised. But there's a chance that it might have enough connectivity to the skin in order to pick up that heart rhythm. Chances are it's not, but we can try. But if we can't get that chest hair off, that AED comes back. So let me back up. We have our victim in cardiac arrest. We've retrieved our AED. That's our priority. We're going to call 911 and then we're going to retrieve our AED. We've come back to our victim with our AED. When placing these pads, if we don't have the ability to remove that chest hair, we're going to place that pad on there anyway. We place this AED on this person, we turn it on, it analyzes. It comes back and says no shock advised. Does that mean that we give up? No, that means that we're going to start our compressions, right? We're going to do our compressions on our breaths until EMS arrives, because when EMS shows up, they have a different device. They have a device that can shock anything, and they probably have a razor too. So we're going to do our compressions. But let's say that we can use this AED. We want to prep that chest, the hair, but not just the hair. We want to dry that chest off. People in cardiac arrest get sweaty. That's what they do. So we want to dry that chest where we're going to place those pads here and here. Make sure that chest is ready. Let's say that somebody had begun CPR while I was retrieving the AED. When I return with that AED, they don't stop compressions. They're going to keep doing their compressions. I'm going to put the pads on around them. And there's a reason for that. When we do CPR, we do create somewhat of a generic, an artificial blood pressure. We want to maintain that pressure. So we want to maintain those compressions. When we stop those compressions, that blood pressure starts to fall and the effectiveness of our compressions starts to fall. So we want to maintain those compressions as much as we can. The only time we really want to stop our compressions is to give those 2 breaths. When we're applying our AED, all AEDs will provide some guidance. They'll give you cues. Maybe not exactly like this one does, but similar.
Adult patient. If the patient is a child, press the child button.
So the pads are very
Remove
explicit
clothing from the patient's
in where
chest.
they go. The pads will show you where to
Remove
place
packet
them.
and apply pads onto patient's bare skin.
I get it. So
Apply
just follow
pads
the
as
directions
shown
on the
in the
pad.
picture.
When we're placing the pad that goes up on the right
Remove
shoulder,
packet and apply
we want to
pads
place
onto
that
patient's
just below the
press
collar.
pads firmly on skin.
And on our other pad, we
Apply
want to place
pads
that
as shown
off to
in
the side
picture.
of the
Press
chest,
pads firmly on skin.
like such.
Do not touch the patient.
Just below the
Analyzing
chest.
heart rhythm. Do not touch the patient. Analyzing heart
It is
rhythm.
important that we don't
Shock
touch the person
advised.
while it's analyzing. If
Do
we
not
touch the person
patient.
while it's analyzing,
Everyone
it's going
clear.
to disrupt its ability to analyze, and it's
Press
going to
the
come back
flashing
and
shock
say no
button.
shock advised. It's important
the
that we
shock
don't
button
touch the
now.
person when we shock. If you
Press the
touch the
shock
person
button
when it
now.
shocks, you're going to get
Shock
shocked.
delivered. Begin CPR.
So I'm going to let this go just so you can see. All AEDs do this. They have a metronome
10.
to help you keep your pace. They count your compressions for you.
20. 30. Give 2 breaths.
They cue you to give the breaths. And the AED is going to go on like that. It's going to have you do 4 more cycles of CPR, and then it's going to have you stop. And it's going to want to analyze that heart rhythm again to see if it's a shockable rhythm. I say that. I mentioned earlier how cardiac arrest occurs when the heart gets into an unproductive rhythm, a bad rhythm, an arrhythmia. There are 13-ish different possible arrhythmias the heart can be in. An AED, an automated external defibrillator, can only shock 3 of those. So there is a chance that you put this on your person in cardiac arrest, there is a chance that it comes back and says no shock advised. Don't be deterred. Do your compressions, help that person as long as you can until EMS arrives. And stay with the AED. Do your compressions. The next time it wants to analyze, it may be in a shockable rhythm. So keep the AED going, keep it at your side while you perform your CPR. When using an AED, it's important to know we cannot hurt anybody with an AED. Like I said, it's only going to shock 3 rhythms. It's not going to shock somebody in a normal sinus rhythm, a good productive rhythm like we are all in. It's not going to shock that person. You do not need to be trained to use an AED. It provides the guidance. They are designed for the layperson to see it in a public space, pick it up off the wall, and help a person. We don't need special training. Anybody can use one. Just in a fun little, kind of a thing, an AED, the battery in that AED has enough power to deliver between 60 and 200 shocks and will run for 4 to 6 hours. So the battery is not a limiting factor when it comes to the AED. You don't need to worry about it dying while you're trying to perform CPR, while you're trying to resuscitate a person. It's not going to die. I think it's important to understand a couple of things. Here in the US, survival rate for cardiac arrest outside of a hospital setting, cardiac arrest that occurs in a hospital is a whole other thing. Outside of a hospital setting, the survival rate for cardiac arrest in the US is 8%. 8% of people that suffer cardiac arrest survive. 92% die. That's staggering. But the good news, if the person is witnessed going into cardiac arrest and CPR is begun immediately, survival rate goes up to 30%. If the person's witnessed going into cardiac arrest, a CPR is immediately begun and an AED is retrieved, it's in the building and immediately retrieved, survival rate goes up to 70%. So you can see how powerful that AED is in surviving cardiac arrest. The AED is honestly everything. I think it's important to understand what's going on. A person in cardiac arrest, for all intents and purposes, that's a dead person. They're not going to spontaneously resuscitate. That doesn't happen. So what CPR does is CPR keeps this person viable until we can get the AED. It keeps blood circulating mostly to their brain, oxygenated blood to the brain to help keep them viable. So that when we do retrieve that AED and we do supply that shock, there's something there. You have to understand that the AED is basically the reset button for the heart. That bad rhythm's going on, that there's an electrical impulse that goes across the heart that makes those chambers beat. That rhythm, that impulse has gotten disrupted somehow. The AED is like a reset button. It shocks across that heart, wiping out that bad rhythm so that a good productive rhythm can return. People don't wake up from simply CPR. You may have heard a story or two about how somebody did CPR on a person and they woke up before EMS arrived. That person wasn't in cardiac arrest. They had an ailment, they had an illness, something was going on with them, but it wasn't cardiac arrest. The only thing that can restore the heart to a good productive rhythm is the shock from an AED. With that, say you don't have an AED in the building, in the vicinity, you are relying on EMS to save you in the event of a cardiac arrest. Your chance of survival goes down by 10% for every minute you wait to be defibrillated. So if you are waiting on EMS to survive a cardiac event, being generous and saying that their response time would be 7 minutes, that puts your chances of survival at 30% if everything else goes perfectly. You can see how critical that AED is in surviving cardiac arrest. It truly is everything. To talk about someone who is pregnant, because I feel like if you were helping somebody that was in cardiac arrest that was pregnant, it would feel weird. It would be weird, I think, especially when it came time to put that AED on the chest. But the fetus's heart rhythm does not interfere with an AED's ability to read the mother's heart rhythm. And that shock from that AED does not pose a threat to the fetus. So we can feel confident in using that if we ever were put into that situation. Here's my chart. This is a chart demonstrating that decrease in survival rate as time progresses. And you can see that average response time somewhere between 7 and 8. You can also see that if we begin immediately CPR and an AED immediately, survival rates are near 80%. Or over 80%. That's all I have for you guys. Does anybody have any questions? Yes?
we're talking about, for example, like a pregnant lady, like using the AED. What about CPR? Like,
Same,
it, it will be hard, like to do CPR like in a pregnant person.
but we need to, we have to. Yeah, the only way to give them a chance at survival is to perform that. We have to do it for the mother and the fetus, right? The mother and the baby. Yeah, that's a good question. Well, all right, everybody, I appreciate your time. Thank you very much.
Thank you.
Alrighty, thank you, Brandon, for this great information. I think I learned, I had took the CPR classes with Karen before, and I was pregnant by that time. So I was like, I had all these questions, and she was so kind to answer me all this. But it's nice to remember, like, when these type of classes remind us to keep, our trainings up to date and our knowledge up to date. So our next Start with Safety in collaboration with the Women in Safety. It will be March 3rd. We will be posting some information on our social media. So be prepared for Shantae Jackson. And stay safe.